if you can just summarize briefly
Sure.
the issue of changing therapy. Now you have a patient that's relapsed, or is refractory to therapy. When exactly do we have to really consider a change in therapy of TKIs?
So for sure, I think we're going to discuss that there is two different main reasons why we change TKI therapy. Will be intolerance, that we will discuss later, and of course, lack of response, right? In terms of the lack of response, I think, once again, we need to really go to our guidelines, our NCCN and ELA guidelines with these subtle differences, right? And again, put some common sense, as we discussed it before, about really get a kind of sense at the time of the milestone how this patient is doing. However, if this the milestone is not really achieved at 3 months and definitely at 6 months, and this is a period, in my opinion, is a gray area where you can really move more to the 3 or more to the 6, where to start with is a patient should be considered to really change to other TKI. This is very, very easy to think, in my opinion, that if a patient starts with imatinib, while I may really be more precise or more aware that, well, depends on the patient I have, I may want to really achieve a better response if it's not really achieved at 3 to 6 months, right? However, in a second generation TKI, I mean, in general, we may be more conservative because we may not have so many options, right? We always say that, well, I may not be so aggressive to really switch therapy. I will wait a little longer to see how things happen. This is the early kind of things that we consider change of therapies. However, sometimes we see patients that they are not being assessed at the very beginning, and they come to our practices, and of course we apply subsequent milestones, right? The classical lack of complete cytoretic response, for example, at a year, right, is, in my opinion, a very, very good argument to switch therapy immediately. Lastly, in terms of major molecular response, although I agree with David, I like to do that. Well, I may be more conservative about switching therapies upon lack of MMR, and of course, patient to patient will be something that I have to really consider, right?
And David, just to round up this a little bit more, Javier mentioned the issue that it can be because of resistance or because of intolerance. How often do you think we really see true intolerance? I've been recently a little concerned whether we're not switching for adverse events that are manageable rather than for true intolerance. Can you tell us your impression about how often is it true intolerance in versus resistance, of course?
Yeah, well, no question for resistance. You need to make a change, and there are choices. Intolerance, as we've said, it's very, very common for patients to have low grade 1, grade 2 toxicities with any of the TKIs. And as we said, fortunately, for most of those toxicities, with time and support, those symptoms abate and patients can continue on. So I'm fairly slow to make changes based on intolerance, and it's pretty rare in my practice that I have to do that. I mean, I do have a patient or a few who have, it's grade 2, but it's definitely interfering with quality of life on a daily basis with one TKI. And I say to them, okay, you've gotten a good response, we're where we want to be, but your quality of life, I think, could be improved. There's very little cross intolerance from one to another, but as you said, Harry, it doesn't mean that you wouldn't get some other toxicity. You have to keep that in mind, and maybe that one would be worse than what the patient has now. But I think since we do have options, you have to keep in mind what the comorbidities are and the patient's, particularly patient's risk for cardiovascular complications. But I think there's options to move to a different drug without feeling that you're going to compromise their control of the disease, but hopefully you're going to improve their quality of life. And of course, after a trial, you might end up going back to the original drug because they may actually feel worse on the second one than the first.
And Harry, if I can ask you, so we changed from a first treatment to a second treatment. Now you're in your second treatment. That starts becoming a little bit more tricky. How long do you give that second treatment before you determine that it's working or not working? When do I know when I need to go to another TKI, or when do I know that I need to go to a transplant, for example, after I've gone in already my second line of therapy.
So let's assume that the switch has been made based on all of the data, which would include ABL mutational analysis. We know, it appears at least, that nilotinib might be a better choice in patients with a codon 317 or codon 299 mutation. Dasatinib may be a better choice for patients with P-loop mutations, and of course, patients with a T315I mutation. That is the labeled indication for ponatinib. So let's say your decision to switch was informed by all of the data available to you. I think there's growing evidence from a number of institutions that outcome does relate to a very early response at 3 and 6 months. You don't have to wait very long. If patients are achieving cytogenetic or even molecular responses early on, then you could rest assured that they're going to do better. The question is, what should be the plan for patients who don't achieve those early responses? And part of it depends on whether you think the patient is still is a candidate for allogeneic stem cell transplant. If it's a younger patient, no comorbidities, a family of 10, lots of sibling donors, it may be a much easier decision to send them to transplant. And we have learned, unlike in our interferon days where we were all warned, if you give interferon more than a year or two, the outcome with transplant is much worse. We haven't seen that in patients who've been treated with TKIs, except if they've progressed into accelerated phase. If they're still in chronic phase, regardless of the mutation that's there, their outcome is just as good regardless of when they are transplanted. So the trick is not letting them progress. I think the more difficult issue is the patient who may not be the best candidate, however you define it, for transplant. Age, comorbidities, donor, whatever it is. In fact, Jorge, you and I share a patient who's 70 years old, has been on all 5 TKIs, has had true toxicities managed by an expert, and couldn't tolerate any of them. The patient's now on bosutinib, and she has persistent disease at the cytogenetic level. Complete hematologic remission, feels great, and she's 70 years old. Okay, so if she was 17 years old, I might feel a lot more strongly about a stem cell transplant. But in her situation, she's choosing quality of life right now. The other thing, I think the last point I'll make here that we have to consider is that I know we're very invested in these cytogenetic and molecular remissions. But a curious observation from, remember the START trials with dasatinib and ENACT trials with nilotinib, is that patients, only about 45-50% of patients achieved these great remissions. But if you look at the survival curves, they're much better than we would have expected. In fact, Jorge, you've published on this from your MD Anderson experience, that patients who have a hematologic remission with an ABL TKI seem to be doing better. And so the conversation I have with that 70-year-old is, this isn't optimal. When we have a clinical trial of a novel therapy that might add to the effects of an ABL TKI or some different approach, let's consider that. But at this point, we're making the decision to continue with what we would consider suboptimal therapy. What we don't know, finally, is if I took that patient to an allogeneic transplant at the age of 70 with a reduced intensity conditioning regimen and an unrelated donor, would her outcome be better than just continuing what I'm doing? We don't know.
Exactly. I think that that's a very important point. I think we always have to keep in mind that our assessment of response and how quickly we need to trigger a change depends on what we know about that level of response and what it means for the patient, but also what alternatives do you have for that patient that realistically offer a better chance. If I have a patient that's treated with imatinib and is, I don't know, at 3 or maybe at 6 months, is falling behind and he's a young patient or whatever, I may want to pull the trigger a little bit sooner. If I have a patient with T359 and it's a little bit slow to respond to ponatinib, what do I realistically have that's going to give a better probability? So, I mean, you need to put these things all these recommendations, and Javier and others have emphasized this point, they're recommendations that give you some general guidelines, but we always have to individualize these to our patient, to what exactly is happening, and you know, we still have to be doctors, not just following you know, a recipe. You know, it's not like, you know, if I pull one of these recipe books for my wife and I do the same thing that she does, it's not going to be the same thing. You know, you need to put a little bit of your touch,
sure
and it's not going to be the same.
Could I